Parkinson's disease affects a part of the brain called the substantia nigra, which is a part of the brain that contains a lot of neurons that use a chemical called dopamine to talk to the rest of the brain. And this part of the brain also smoothens out a lot of our movements and also is involved in a lot of automatic movements, like for example how I'm moving my hands, or if I'm walking I'm swinging my arms, or even smiling, and natural movements that we have, or all the little gesticulations that we take for granted, for example, right? Those are actually part of Parkinson's disease that gets affected by Parkinson's disease. These are controlled by a part of the brain called basal ganglia, and the area that I mentioned, the substantia nigra, along with subthalamic nucleus, thalamus, and the basal ganglia, they all combine to form a large circuitry, all of which is affected in Parkinson's disease. So in Parkinson's disease, what happens is there is a type of a protein clump called Lewy body. In Lewy bodies, we have three types of proteins, commonly known as alpha-synuclein, parkin, and ubiquitin. These three proteins clump together to form somewhat of what we call a trash can in the brain. This actually starts building up in these cells and they kill the cells. First, they start showing up as a tiny, sort of a, abnormality, a brittle, sort of a long, elongated abnormality inside the cell's connections. Then they extend into the cell's body and then kill the cells. Once the cells die, after a certain amount of cells have died, what happens is the brain starts showing the effects of lack of dopamine, which means if you don't have enough dopamine, your natural movements go away. So patients start walking like a robot. Patients won't blink as much, might not even smile as much as they did in the past, or do not swing their arms. These are the early features that we see in Parkinson's disease. People think of tremor as the main thing that we see, but in fact, if you look at the patient's family photos or ask the wife or the husband or the spouse, they'll say, oh yeah, I've seen the patient not smile anymore in the pictures, or she's been walking without her arm swing, so I can see her kind of shuffle a little bit, things like that. There are a few other features that we have seen as Parkinson's disease prodromes, historically speaking. So when we looked back at Parkinson's disease patients and looked at their videos, we saw that they were not walking with their arm swings. We have looked into celebrities with Parkinson's disease and even looked at how they actually played a game. For example, soccer players who didn't swing their arms when they're kicking a ball, and that was the earliest feature that we could find like 5 years ago. This was already there, and 5 years later, the patient gets diagnosed with Parkinson's. So these are prodromal features that we always look for. Some of the non-motor features, which means features that we don't see with your eyes, but you can ask the patient and they'll tell you. One of them is lack of sense of smell. Gradually, they lose their sense of smell. And this is something that you don't see right away, but when you ask them, hey, can you taste the smell of, or taste the mint in your toothpaste, or are you able to identify the smell of brewing coffee in the morning? And they'll tell you, yeah, that's been kind of going down for a while, right? Usually you have to check with the spouse to see if this is true or not, because patients might not even recognize this thing. Another thing that we see is called REM sleep behavior disorder. REM stands for Rapid Eye Movement Sleep Behavior Disorder, or REM-BD. In REM sleep behavior disorder, what we see is patients start having nightmares and they act out their dreams in the nightmares. So they basically start fighting or boxing in night in the bed, and sometimes the spouse gets woken up because they are so active in their dreams. Sometimes they just talk. That's also something that we see. So these two features, lack of sense of smell and being very active physically at night in their deep dreams, are very typical for Parkinson's disease patients to show almost 5 years before the symptoms start. So the idea within the field is that the brain changes start happening almost 5 to 7 years before the patient starts showing the tremor or the lack of arm swing or the facial changes. Parkinson's disease classically has 5 features. One is the tremor. The other one is called rigidity, which means it's a stiffness of movements. And then you have bradykinesia, which means they have slowness of movements. And these things can be assessed. Like rigidity, I will have them move their arms around, I will have them walk a little bit, things like that. Then you have postural changes, which means they can look like they're hunched over a little bit when they stand up, and when I ask them to stand tall, it can be corrected. Sometimes they'll have balance issues when they're standing up too. The other thing is the gait problems. When you see them walk, you can see that they don't pick up their feet much. They have a little bit of a baby shuffle. That's usually, rare, but most patients, when they start having the disease symptoms kind of affect their body, we'll see some of them too. For all of this, the best medication that we have, and this has been the medication since the 1960s, and we have had variations of the same medicine, it's called the levodopa. Levodopa becomes dopamine in your brain. So if you can think about, how this works, it gives you back the dopamine that your brain was not producing when all those cells were dying away from Parkinson's disease progression. So giving you levodopa in different forms is the mainstay of treatment for Parkinson's disease. And this gives you the dopamine to that part of the brain that helps you with that natural movements. So most patients will get that arm swing a little bit back. They'll also start feeling a little bit more powered up, as opposed to feeling like a powered down robot, which is the words that patients often use when they are feeling low without the medication. So once they start taking the medication, and it'll take a little bit of time for them to really adjust to the medication, because this medication can cause a lot of nausea, sometimes even dizziness. So I will give them a slow, progressive dose, starting with a small dose, gradually increasing it over about a month or so. The way I describe it to patients is that dopamine is sugar. Dopamine agonist is like Splenda or stevia. It's like sugar, but it's not really the dopamine. So if you are a young patient, let's say you're in your 40s or 50s, and you want to try something different from levodopa so that you can save for later the levodopa, then you can try dopamine agonists. There are some other medications also that are used called trioxyphenadil, benztropine. These are medications that are very specific for tremors, very specific for a particular problem that comes with Parkinson's. In Parkinson's disease, the medication timing is very important for two reasons. One is, as you grow older with the disease, it affects the way your digestive system absorbs the medication. So you gotta really be careful with what you take with levodopa. The second reason is because levodopa itself has a way of disappearing from your system. So let's talk about that part first. So levodopa, if you take 100 milligrams of levodopa, up to about 80% goes into your brain within a matter of 20 minutes or so. That 80 milligrams that gets into your brain becomes half of it, which is 40 milligrams, within about 4 hours, which means your brain is losing half of the levodopa that you're taking every 4 hours or so. The other thing is the digestive part, right? So if your digestive system is affected by Parkinson's disease, you might not absorb the medication properly into your system. So we have devised some ways of it. For example, a type of levodopa called Rytary, which is actually a capsule full of little sprinkles of levodopa, and these things are designed in such a way that they open up in a particular part of your GI tract, then release the sprinkles, and each of these sprinkles are coated with several layers of levodopa. So it gets dispersed into your body at different times. So this way you can treat that as well. The other thing is, make sure you don't take a lot of proteins with levodopa. Levodopa gets into your brain through the GI system using the tiny gates that are used by proteins. If these gates are full of food protein, levodopa just hangs around in your GI tract and gets discarded, right? So you need to make sure that you take the medication before about 30 minutes before your meal, or avoid taking a major protein meal with levodopa, because once you have a lot of proteins hanging around your GI tract, it'll clog up all these little gates that levodopa uses. And this is important for most medications, but particularly important for levodopa. So I tell my patients, take levodopa 30 minutes before your meal, or wait for an hour so that the meals have gone. Whatever needs to be absorbed has been gone as well. Now you can take the levodopa. Parkinson's disease patients often have constant, muscle movements without them knowing. Their brains tell their bodies to move, and if they have a tremor, they're also exercising their muscles in their hands or their feet, right? Which means they can lose weight quite a bit. The vast majority of patients with Parkinson's disease, when they have the disease uncontrolled, they can lose quite a bit of weight. Once we start treating them, once we control the movements, they don't lose a lot of weight because their constant muscle movements are gone and they don't burn calories just sitting there. But you have to watch what they eat because of this issue with interaction with levodopa and food. So they sometimes get too obsessed with taking the medication and not eating at all, which can lead them to malnutrition. So we usually, tell them, hey, this is a thing. Don't live your life around the medication. Try to live your life, and the medicine should be really helping you, not that the other way around. So make sure you eat appropriately. Once you have adjusted medications for, let's say, 3 or 4 years, and they have progressed beyond that initial stage, that's when we start discussing, hey, we probably need to consider more surgical or advanced therapies, right? So we generally have 3 options here. In tremor and rigidity predominant type of Parkinson disease, deep brain stimulation surgery would be a great option for patients who have had 3 or 4 years of the disease and they are still kind of dependent on medications, and they are sometimes telling me, hey, I have to watch the clock all the time. I'm taking the medication 4 or 5 times, 6 times a day, and there's too many medications. I feel the side effect of it. Is there anything else? That's when I will say, hey, let's look into deep brain stimulation surgery. If it is tremor only, focused ultrasound can be actually an option for them. And then we have something called liquid or infusion of levodopa. So levodopa comes in liquid form. You can actually put it into their belly directly using a feeding type tube-like device. This is called Duopa. At the moment, Duopa is the only manufacturer that actually has approval in the United States. There are several other companies that are going to come in the next couple of years, and we have gone beyond that infusion, and we have now gone into the era of subcutaneous injections. So these will be skin injections. So we're basically taking a page out of the diabetic treatment. Just like you have insulin pumps where it goes directly into your skin, we're going to have levodopa in infusion pumps that'll go directly into your skin. So these are the advanced therapies that we offer here.